even that doesn't define cytogenetic. Cytogenetics also do not define certain class of patients who come into the high-risk myeloma. Let's see what this is. So this is according to the NCCN guidelines in the newly diagnosed myeloma, revised ISS 3, extramedullary disease, circulating plasma cells, and these particular cytogenetic abnormalities, which include deletion 1p32, translocation 414, translocation 1416, translocation 1420, 17p deletion, monosomy 17 or TP53 mutation, 1q21 gain or 1 to 1q21 amplification, MYC translocation, and high risk gene expression profile. These constitute the high risk cytogenetic profile or molecular profile for the newly diagnosed myeloma. For the relapsed myeloma, a disease which is relapsing within 2 years of initial therapy, when the transplant and maintenance is used, relapse within 18 months in case of non-transplant based treatment, a new acquisition of 1q gain amplification or acquisition of deletion 17p or TP53, and extramedullary presentation at relapse or having circulating plasma cells. So these are the high risk factors. So patients who present with two or more of these cytogenetic risk are considered as very high risk disease, so which is more at risk of disease progression or relapse. In this particular NCCN guideline, they say that sole abnormality of 1q21 is not considered as a marker for high risk of progression or relapse. But we will see further that how 1q abnormalities, whether it is a gain or an amplification, does affect the prognosis of the disease. So this is how the ISS staging has progressed over a period of time, starting from ISS to R2 ISS. R2 ISS is only validated for newly diagnosed multiple myeloma. So the classification, the stress stratification, which is used mainly in the clinical setting presently, is the RISS. But as we can see, we are not covering what the genetic abnormalities that there are various drawbacks or shortcomings of the revised ISS. Let's see what are those. So the main limitation of revised ISS score was that only there was 62% of the patients were classified into the intermediate risk category. Means that which do not fit into ISS 1 or revised ISS 1 or revised ISS 3, were majority of the patients were lying in the intermediate risk category. And probably this included the patients with different risk levels of progression and death. So it was not very clearly defining the patients based on that. So recently, even 1q gain or amplification, which were not included in our ISS, were proved to be independent prognostic factors of the newly diagnosed multiple myeloma. Oh, the risk in the RS-ISS, only deletion 17p, translocation 414 and 1416 were considered. Whereas it is emerging data shows that more than one high-risk cytogenetics can predict poorer outcomes. So these were the limitations of revised ISS. Now, what about 1q abnormality? 1q abnormality is a very common finding in newly diagnosed multiple myeloma, seen in about 40% of the patients with are seen with this abnormality. So, what are the types of 1 chromosome 1 abnormalities? Chromosome 1 abnormalities can have additional copies of any part of the long arm of chromosome 1, irrespective of the copy number of segment of DNA that is gained. Now, gain of 1q is having only one extra copy of chromosome 1q, whereas amplification of 1q is is at least two extra copies, two or more extra copies of chromosome 1q is called as amplification. Trisomy, when both the arms, P and Q arms of chromosome 1 are gained. So this is trisomy 1. And chromosome 1 abnormality includes any abnormal signaling, whether it is in 1q or in 1p. So it has been most extensively studied. It is also seen in 30% patients of smoldering myeloma, and it appears that presence of 1q abnormalities is an independent risk factor to predict the progression of smoldering to multiple myeloma. So in this total therapy 2 trial, it was seen that patients with 1q abnormality had similar response rate, but they had worse progression-free survival and overall survival. Now, as briefly we had said in the description, what are ultra high-risk myelomas? So this is the definition of ultra high-risk myelomas, myelomas which lead to death within 24 months. Despite the availability of all the newer drugs which are available in our armamentarium, still these patients represent around 15 to 20% of the total myeloma population. So many of these factors, this is a combination of all the factors, and it is not just ultra high risk myeloma. We cannot define just on the basis of cytogenetic risk profile. Presence of two or more cytogenetic risk factors make it a possibility that the patient may have a ultra high risk myeloma, but multiple factors, including patient related factors, disease related factor, all of them when combined together are contribute to what is called as a ultra high risk myeloma. Now defining what is extramedullary disease versus paramedullary disease. So we come across many patients who present with a bony lesion which have a contiguous soft tissue involvement. So that is called as the paramedullary disease. Extramedullary is defined as where there is hematogenous spread and it is separate, not in the contact with the bony element. So there is a lot of difference. We'll just see how the graphs differ with respect to EMD and PMD. Now, this is another entity which is very important in the era of CAR-T, basically, what is called as functional high-risk myelomas. Now, it refers to the patients who relapse or die within 12 months of starting the treatment, and they were not initially classified as high risk based on ISS score or based on the cytogenetic profile or a risk stratification system. They are initially not classified as a as a high risk, but they behave poorly. So this category is the ones who poor prognosis, and they are usually, because they are not identified, they approximately 22% of early relapse patient and standard cytogenetic. This was reported. ISS1 was reported in 22% of these early relapse patient, and 12 to 28% of these patients had standard risk on presentation. Now, what is triple class versus penta-refractory myeloma? Triple class refractory is defined as refractory to at least one of the immunomodulatory agent, emits a proteasome inhibitor and an anti-CD38 antibody. Whereas penta-refractory is defined as refractory to len, pom, boti, carfil, and dara. So this is just for the, because we need to patients who were triple class refractory, they fared slightly poorly than the patients who were not triple class refractory, whereas penta refractory patients fared worse as compared to patients who had not been penta refractory. Extramedullary, also the same thing. Patients who had extramedullary presentation who had a much worse survival, and presence of high-risk cytogenetics also contributed, but not as much. So we'll come to, this is a meta-analysis which was from around 17, sorry. Anybody said something? Okay, so this was a meta-analysis of 17 studies in which cytogenetic high risk was defined as deletion 17p, or the same as defined by NCCN, and disease-specific risk was also defined as presence of extramedullary disease or RISS stage 3. So in this high risk versus standard risk, how did they fare? So high risk cytogenetic profile was significantly associated with worse overall response rate. Just 1 minute, excuse me. Yeah, sorry for that. So, presence of high-risk cytogenetics was associated with increased lack of response. There was 23% increased risk of MRD positivity, and high risk was significantly associated with worse outcome. There was 70% increased risk of progression or relapse or death. So, it was associated with worse overall survival as well. Now, EMD versus no EMD. So what was seen was that extramedullary disease, they were not significantly associated with a worse overall response rate. Means the response rate was comparable to the patients, but in terms of PFS, they did significantly worse. So presence of extramedullary disease at the time of CAR-T was associated with a 44% increased risk of relapse or progression or death after treatment. That's about EMD versus no EMD. Uh, Now, this is just a meta-analysis. Sorry, this is comparing the cilta-cel and the ida-cel, which was seen in extramedullary myelomas. So the overall response rate was 58%, whereas in the patients with extramedullary disease, whereas it was 96% in patients with no extramedullary disease. So again, there is the data is controversial because earlier that meta-analysis mentioned that the response rates were not different, whereas there was a difference in the PFS. But here we can say in this data of cilta-cel and ida-cel that the overall response rate was also lower. So EMM predicted high early relapse and progression. So this is it. Yeah. Now this is the comparison between extramedullary versus paramedullary disease. Paramedullary disease, as we can see, did similar to the patients who did not have either of the presentation, whether extra or paramedullary. They did similar to that. Whereas extramedullary, it did significantly worse in terms of PFS as well as OS with CAR-T. So now coming to the outcomes of functional high-risk myeloma patients, which we defined as patients who did not have any risk profile right in the beginning of the presentation, which we did not define them as high risk, but they behaved like the high risk. So these patients are the ones which, according to the recent data, should be as we can see from the presented data, that CAR-Ts are not working very well in patients who are proven to be high risk, as in if they have an extramedullary disease or they have a high risk cytogenetic profile, they are not doing very well. So which patients will do well? The patients with this particular category, where functional high risk myeloma, have been seen that they are the target population for CAR-T, and they have shown much better results according to this abstract. So usually they have a poor prognosis regardless of their risk profile at diagnosis. So the findings were that functional high risk could be a useful tool for identifying the patients with poor prognosis. Uh, One more, I think I have one more slide here. Yeah. So patients, how did they do who had received second line therapy and they had functional high risk myeloma? So they did significantly better. So with cilta-cel, with the available CAR-T versus comparing to the in terms of overall response rate, patients achieving MRD negativity and CR. All of these responses were significantly better in patients with functional high-risk myeloma. So recognizing the patients who are not doing well with the standard of care in the first line may be the ones which we would like to target early especially after these the therapies, both ide-cel and cilta-cel have been approved in the earlier lines. CAR-T has been approved for them. So now this is the question which I would leave you all with, probably which we can answer in the subsequent lectures. That is MRD negativity a better surrogate for longer PFS? Since now we can see that high-risk cytogenetics or any other is not a predictor for who will do well with what kind of therapy. Maybe MRD negativity will be a better what we say, a surrogate for predicting which patient will respond better. So in this, based on sub-analysis, high risk from the pivotal trials, it was seen that many high-risk cytogenetic patients with after 3 or 4 drug regimen followed by autologous stem cell therapy, their dismal prognostic effects were abrogated. So maybe we are proceeding towards that. So we can have our next discussion on MRD negativity and its significance in myeloma and with respect to CAR-T. So thank you so much for your patient hearing. Thanks a lot.